Should I zoom out? Yeah, I can zoom out.
Right. Right. So you're trying, and then it's like, well, that didn't work. And that's an environment that greatly is created so that it just got that sense of like, swing. You know? Oh, wow. They had a school board, we had a superintendent here, and the entire board here, and he would not affiliate with the school. Most of our staff is staff, which is fine. But most systems, okay. We made it happen. We made it happen. Well, we
Who's it?
we don't want this to be a heavy lift. But that's why I sent the questions out. We also
No.
know we want to set more than her. Because that's what they'll say to think about. What you did, right. Yeah. We're going to be a little close together there, but and then Christina. Yeah.
Whichever chair you don't want them to sit in. That might be where we go. Whichever one is going to be in the way. And then just put it like back here.
Back?
They're going to be a little tight, but hopefully we'll. Right. Well, that'll be. Yeah.
Well, you have lunch.
Yeah. Oh, thank you.
Also, like, you get a pass when you're on camera because, like, I quit. Leave me alone. Okay, so there's the street. Yeah, that's what it looks like right now. The street. When they walk up. And I'll give you a second.
We'll get up there and
Is there anything else?
I don't know if anybody's watching. Do we want anybody to watch the stream to see if there's questions? I don't
Sure.
think there. Well, just look over every now and then.
Yeah,
There you
look
go.
over there once in a
Yeah.
while and let me know. Hey, how are you doing? Good to see you. Nice to meet you too. Thanks for coming.
That's awesome. Hey guys, we just got told that we can share.
I was gonna say we got 2 spots here,
Yeah.
and I trust you guys not to touch the tables.
Yeah.
So
Can I get another chair so we have 3?
let's see. Well, let's see
Let's
what's a
try
shot.
it.
Let's try it.
I'll sit a chair.
Let's see.
That would be awesome. Come on through.
The other option is if you come over enough.
I'll show you.
Whoever's and if we need to,
Check out camera.
that's fine. That's fine because that's their legs. We can see all the faces. It has an autofocus feature, so it detects the move.
Yes, isn't it?
So actually, both Mike and I are taking attending the help center. And I'm so sorry to say this, but I think it's probably
Jessica, really fun. No worries, no need to apologize about that.
oh my gosh, am I familiar with that?
Yeah.
I went face. I've always been up higher. I have an incredibly chaotic newspaper. I do all of my work in
You guys are the documents, correct?
Yes.
Okay.
Yeah.
Okay.
Yeah.
I was just making sure because you helped setting up earlier, but when Sam was like, can you get pictures of the documenters? And I was like, wait a second.
Yeah.
I'm Molly. I'm the art director.
Jessica.
Nice to meet you guys.
Yes, nice to meet you as well.
All right, thank you everyone for coming tonight. Really appreciate the turnout. Looking forward to a meaningful conversation, hopefully some solutions surfaced, certainly discussion of gaps in our mental health care system and the people who need us to focus on those gaps. I'm Ziva Brandstetter, I'm the CEO of the Tulsa Flyer, and we also publish the Oklahoma Eagle, the sister newspaper in our newsroom. I want to thank our sponsors tonight, Healthy Minds Policy Initiative, additional support from Oklahoma Women in Tech, and Experience Tulsa. I don't know if they're here. Thank you for amplifying this event. And I want to introduce our panelists, but I'm going to give them a little time to talk more about what they do. So starting with Christine Marsh, she's Executive Vice President of Family and Children's Services, and she focuses on child abuse and trauma services, and is been at this a while and really an expert in the role. She leads efforts to support children and families navigating the impact of abuse and trauma. This is work that sits at one of the most critical intersections of child welfare and mental health care in our community. So welcome, Christine. Zach Stoikoff, next to Christine, is the founding executive director of Healthy Minds Policy Initiative, and this is a Tulsa-based nonprofit that works with state and local leaders to develop data-driven solutions to Oklahoma's mental health and addiction crisis. So under Zach's leadership, Healthy Minds has helped bring millions of dollars in new treatment resources to Oklahoma, and has really been instrumental in passing some of the nation's strongest state legislation that has expanded access to behavioral health. It's also, Healthy Minds is also a major funder of tonight's Snapshot Mental Health Project, which some of you can see around the room. Ishmael Lely is a reporter for the Oklahoma Eagle, which is, as I said again, a sister newspaper to the Tulsa Flyer, one of the oldest Black-owned newspapers in America, and a publication that we're very proud to support and lift up. Ishmael's reporting for this series focused on mental health stigma and access within Tulsa's Black community, exploring both the cultural barriers that keep people from seeking help and new avenues opening up for treatment. So he'll be talking about that reporting, as well as Garrett Yelch, a reporter from The Frontier, which is a funded media partner of the Flyer. He's works for The Frontier. It's an investigative news organization that is also a nonprofit like the Flyer. And he's a Tulsa native. Garrett has built a reputation for accountability journalism, including a major investigation with ProPublica that exposed organized crime and labor exploitation in Oklahoma's marijuana industry. And more recently, he wrote an investigation into 7 deaths in 3 years that occurred at the Tulsa jail, and we'll be talking some about that tonight. And last but certainly not least, we have someone who's been doing this work in Tulsa for many years, and that's Mike Rose. He's a licensed clinical social worker and one of Tulsa's most respected mental health leaders. He served as the CEO of the Mental Health Association for Oklahoma for 27 years. And is now a consultant for the Tulsa Day Center, and they're focused on reaching the people who are the hardest to connect with care. He received the 2025 Lifetime Compassionate Tulsa Award for his decades of service. So welcome our speakers. So I'm going to go sort of ping pong back and forth between the panelists here, and then we're going to leave time for questions at the end. This is being live streamed as well. And so there'll be a link after this if you want to share it with folks who couldn't make it here tonight, that there'll be a link to share this discussion. I want to just recognize that there are a lot of people in the audience that I see that are doing hard work in this space, that are either partners of the Flyer, that are working in the mental health community, that care about this issue, and I just deeply appreciate you all coming and being part of this discussion. So let's start off with Zach, and I want to talk about calls to Oklahoma's 988 crisis line. They've nearly doubled since 2022. That's more than any other state. Your data found that the FCS 911 collaboration in Tulsa saved the city almost $110,000 in just 6 months. Given that federal funding for 988 runs out in September and Oklahoma has not established a telecom fee to replace it, what's your honest assessment of where things stand and what needs to happen?
Yeah, thank you, Ziva. You know, this was part of a national trend. What do we do when somebody's in a mental health crisis? They are a danger to themselves or others, they're having thoughts perhaps of suicide or something like that. And nationally, we decided to create a 3-digit phone number, 988. There was already a national suicide hotline that was converted to 988. Oklahoma was, of course, an adopter of 988, but what we did really well, Ziva, is we created a crisis system surrounding that phone number. And what I mean by that is we now have, in virtually every community in Oklahoma, the ability to dispatch mental health responders to you in the event of a mental health crisis, and we often have a facility for you to go to, a short duration stay to receive some emergency immediate care. What is happening now, of course, is some of those federal dollars are going away. The state is resourcing much of this system through state dollars, but there is a series of bills this legislative session that are continuing to advance from Senator Stanley and Representative Norwood, which would start to fund and create a statutory sustainability model for 988 and this larger mental health crisis system in Oklahoma. So I think it's one of the bright spots of what we're doing well in the state.
Amazing, thank you for that. I'm going to come back to some of these systemic issues, but I wanted to talk about sort of stories of trauma that really can teach us something. And Christine, our snapshot project included a profile of a Tulsa woman whose unaddressed childhood trauma led to substance abuse. It led to the loss of her children in foster care, and years of struggling with untreated mental illness. So your work at FCS really sits directly at that intersection. How early does untreated childhood trauma manifest in ways that set off that kind of cascade? You know, how might different outcomes be if trauma-informed intervention came early?
I love your question, Ziva, and I thank you for asking it. I've been in the field almost 30 years. I'm also a licensed clinical social worker, and I can tell you when I started, we were helping children from 3 to 18. Those were the ages that we focused on. And what we quickly started finding were some of the younger siblings that were coming in that were nonverbal, that were wearing diapers. We were trying to get creative and figure out how do we help these young children too, because they've also had similar experiences to what their older siblings have done, but they don't have the words for this. And what we have found over the years, thank goodness, is that we know that children in utero can be impacted by trauma. It can alter their DNA, it can alter what their known experiences are. So if you have a caregiver who is in domestic violence relationship, for example, that can be transmitted to the infant. And so to your point, if this young woman could have had services maybe when she was a child, then some of those adverse childhood experiences that we have heard about, learned about over the last couple of decades could have been not prevented. Obviously, something happened, but we could have provided services to this individual that hopefully could have explained some things and helped things to be understood, processed, and if she had a safe, stable place with the education and wherewithal to treat her trauma. And then it could have hopefully prevented some of those additional things that you talked about with the substance abuse, having her own children placed in foster care, etc., that repeated that generational trauma cycle. And that's the other thing that we see very often is the generational trauma. And so certainly helping her is one thing. The question mark would then be what also maybe were her parents needing, etc., so that we can interrupt just not only her trauma, but also her parenting, so that her children also don't have that same exact experience of that repetition.
So that's an argument for earlier intervention, or family children's services is in schools, sort of treating the family as a whole unit, which takes commitment and legislative help and so forth.
Absolutely. That and understanding that just because a child might not have huge behavioral signs or symptoms, sometimes the quiet kids are struggling as well. And so it doesn't hurt to take children in and have them have an assessment and just talk to somebody, if nothing else, just to see how things are doing. We don't wait necessarily all the time until we have a cavity. When we go to the dentist, we're typically trying to get our children in at age 2, 3, 4 to prevent those things from happening. And that's the way we want to try to look at children's mental health.
Great, thank you for that. Mike, I want to turn to you and talk about one of the stories we did as part of our Snapshot program that our partners at Focus Black Oklahoma worked on. It was a really touching narrative about the life along Admiral Place corridor, where people were living in a very transient state, and there were folks that were struggling with untreated mental illnesses. So you spent nearly 3 decades building Mental Health Association of Oklahoma, developed 1,500 units of affordable housing, really helped pioneer co-responder programs. The Snapshots reporting on Admiral Place found that homelessness and mental illness are deeply entangled. You can have, of course, one without the other and vice versa, but that housing instability itself has a relationship to mental illness. I think it's oversimplifying it to say it causes it, but it certainly doesn't make it better. So in your view, what does Tulsa still fundamentally get wrong about this relationship?
Well, I think, first of all, again, homelessness doesn't necessarily cause mental illness. Mental illness has its own sources. There are people living in recovery with mental illness, and they're housed, and they're doing well. They're in recovery every day, but untreated. Again, it ties back to things like 988, access, crisis intervention, ties back into unaddressed trauma sometimes, and people find themselves then homeless. And so, it takes a lot of work and outreach to begin to talk to these individuals and help them with all the barriers. I think people don't really understand, if you're homeless, all the barriers it takes to get back into affordable housing. It's an amazing, and so people get trapped in this, what becomes a lifestyle of habituation of living on the streets and living homeless. And what do? We oftentimes blame the homeless, and rather than looking at our systemic issues that keep people in that state and not help them overcome that.
Could you talk briefly about the work of the Blue Team and this condition known as anosognosia, and tell folks what that is. I'm sure a lot of you all know, but talk briefly about it.
You pronounced it correctly. I'm really.
I worked on it.
Nice job, Ziva. Anosognosia. How many out there can raise their hand and say, I know what anosognosia is? Hey, we're making some serious progress here. There are a lot of really highly trained mental health professionals that don't know what anosognosia is. It's really important. We used to always see this. It's a symptom, actually, of schizophrenia, schizoaffective, bipolar disorder, where damage is actually done to the frontal and right side cerebral cortex, where what's located at that part of the brain? Inside. So they have no insight into the fact that they have a mental illness. We've been working real closely with Dr. Javier Amador, who's nationally, internationally known as an expert and a pioneer about anosognosia. And his book, if you're interested, it's aptly named, I Am Not Sick, I Don't Need Help. And when I read that, that's what they say. That's what they'll tell you when you try to reach out, because they have no insight into it. So if you don't believe anything, if you don't believe there's anything wrong with you, if I tried to, I don't know if you're diabetic or not, Ziva, but if, assuming you're not, I tried to talk you into it, say, Ziva, you got to start taking your insulin. You're diabetic, and you'd say, Mike, I'm not diabetic. It's exactly the same as that. So it becomes a huge barrier to people accepting help. And so that's what we, with the Blue Team, through the Day Center, we're trying to address. And we're teaching not only people here in Tulsa, we're starting to teach people around the country about what that is, because we've got to understand it.
Interesting. Thank you for that. So Ismail, I'm going to turn to you and then to Garrett. You guys can talk a little bit about your reporting. Your reporting found that only 30% of Black adults with mental health conditions in Oklahoma have sought treatment, and that the stigma made the reporting harder because people were reluctant to talk. What did you learn about why that stigma exists and persists?
Well, I think a lot of the hesitancy really stems from a history of medical racism and distrust within the Black community. As for why it still persists, I think we can look at the different avenues the Black community has taken to cope with mental health instead of actually seeking out professional help. One of those is religion in the church, which is a very strong component within the Black community. And throughout my reporting, what I learned from all my sources is that they had heard at some point that people should just pray about it when it comes to dealing with their mental health disorders.
How common is that? Is there a generational aspect to that attitude?
Oh, for sure. Older folk, most of the sources I spoke to were in their early 40s, and what they had told me from the older generation was that they were a lot more stern and a lot harsh on how they spoke about mental health. So it did soften over time, and it is softening now, but we're still not over that gap yet.
I want to come back to some of the people in the community that are doing the work to overcome that, like the Black Mental Health Alliance. But I want to talk to Garrett about some reporting that he did that, I think everyone needs to know, whether you're working in this space or not, just living in Tulsa, that there's some concerns in the jail. Talk to me about the investigation you did for the Frontier that found at least 7 people have died in the city's jail over the past 3 years. This is not the county jail. This is the jail that was created after the 2 agencies basically couldn't agree on funding. This is a death toll that is strikingly high for a facility of its size, and not surprisingly, this is falling heavily on people with mental illness. 2 young men with diagnosed mental illnesses died by suicide. Talk to me about what your reporting tells us about how people with serious mental illnesses are ending up in this city jail, and what should Tulsa be doing differently?
Right, so I think few people even know that the city has a city jail that's distinct from the county jail, so I think it's worth first kind of explaining what it is. So this jail, it was opened in 2018 after the city had a disagreement with the county jail, David Almas, over funding, basically, that the county was wanted to charge too much. And so the city decided to open its own jail. It's underground, under the municipal court, and it only holds municipal arrestees, so people arrested mainly for things like trespassing, public intoxication, unpaid traffic tickets, shoplifting. And so, in talking to former detention officers, many of them say that, they estimate that 70% of detainees in the jail struggle with serious mental illness. And so it's a lot of homeless people, a lot of, Tulsa police are getting called out to businesses and quick trips, or someone causing a disturbance in public. And so it's that population that struggles with mental illness that is getting caught up there.
And my understanding is that the process is people come into the jail and there's not a medical staff there to assess them, right? It's just
right. It's just detention officers conducting a medical screening. These detention officers have no medical training, and we found repeated violations where they're admitting people into jail that are dangerously intoxicated, or they are struggling. They have some kind of disease that's life-threatening, and they're just admitting them in anyway.
Thank you for that. We'll come back to more of your reporting on funding, which is a topic I want to switch to for all you guys. Zach, Healthy Minds has been central to some of the strongest behavioral legislation in Oklahoma in recent years, but this reporting we did in Snapshot shows significant funding cuts. The Frontier was reporting some of that. It's still really rippling through the providers here. Mental Health Association of Oklahoma lost nearly $700,000. I know Family and Children's Services had significant cuts. The Department of Mental Health is still recovering from this. So what is the gap between the policy wins your organization and other organizations have managed to achieve and the reality on the ground? Are we just completely set back to square one? Or are we is it 2 steps forward, 1 back?
Yeah, it's a great question. We're not completely set back to step one. What I would say is that we're in the midst of a leadership crisis in mental health in Oklahoma and a leadership transition. And what I mean by that is we once had a very strong public agency, the State Department of Mental Health, that really oversaw, it still does, oversees, funds, regulates much of the mental health safety net and substance abuse services safety net in Oklahoma. While that agency still does that, we've seen really a dearth of leadership. We've seen an agency that has been unable to produce a budget, very basic things the legislature would expect it to be able to do. We've seen an agency that really is starting to look at really some foundational accounting practices rather than forward thinking about the strategy about how do we transform mental health outcomes in Oklahoma. Here's what's the bright spot of this. The bright spot of this is the leadership is occurring outside of that agency. The Attorney General's office is distributing millions of dollars of opioid settlement funds paid by opioid manufacturers, distributors, who are basically being held accountable for this massive crisis that caused so many deaths across America of overprescribing, right? Those dollars are now flowing to communities for treatment services. Cities and counties and towns across Oklahoma are starting to realize that we've got to do something about this. Number one, because we know that if we don't, we're saddled with those costs anyway, because what happens if the treatment system isn't doing its job or isn't capable of it? The criminal justice system steps up, and then cities and counties see those costs. So we're seeing cities and counties take that in their own hands. For example, Oklahoma City, in partnership with my organization, just released a mental health needs assessment building off of a community-led strategic plan for how do we transform outcomes over the course of time. The city of Tulsa has been doing this for a number of years. We pulled down $13 million in federal grants to transform children's mental health services. It's the first step in that in the city of Tulsa. The city of Edmond, I mean, I could go down the list. Cities are starting to realize that they have a role in this, and I think that's exciting. But the reality, Ziva, is that we live in a state where 38% of the individuals in incarceration in Department of Corrections custody have a serious mental illness. 38%. Would anyone care to guess the share of Oklahomans who have a serious mental illness? 5.6% have a serious mental illness. Now that would be a schizophrenia, bipolar, massive depression, not any mental illness.
Really over-indexed.
So we are arresting people with these issues, these medical issues, instead of largely treating them, and that is a major, major issue with cost effectiveness and with human lives.
I know it costs about $36,000 a year to lock someone up in a DOC facility. What is adequate mental health care treatment cost?
Substantially less than that.
Let's see, I want to go to Christine and talk about this funding issue and how it affects FCS. You all serve 1 in 6 Tulsans about. Big responsibility, a lot of programs. I know the state recently cut the crisis stabilization unit contract. You've said that you don't anticipate disruption exceptions right now, but also you all can't hold on indefinitely without some kind of impact. What does the realistic horizon look like, and what does it mean for patients if that crisis stabilization capacity shrinks?
Thank you for asking that question. You know, we were luckily able to manage a lot of the cuts that we sustained by reorganizing, not filling positions. Unfortunately, that also means we don't necessarily get to follow some of the more advanced models we would hope to follow, but we were able to keep the doors open and access open and not limit folks. What it means long-term, though, is a different question, because those short-term fixes eventually end, and ultimately it'll mean that services may get cut, which could mean that somebody doesn't get what they need, and that could be a life or death situation. The other thing that we do know is the services that are offered, we're able to have beds, we're able to have somebody respond in crisis. Those are things that keep a person alive, number one, and number two, as Zach's already spoken about, you don't incur the expenses then at a hospital, an emergency room, or a higher level of care. What you're also able to do is keep that person in their community. So in their community, they can work on coping skills, they can work on supportive services, they can work on their health, they can work on their relationships, they can keep working and or going to school. So by taking somebody out and going inpatient, which is necessary at times, all those things get disrupted. So here we are looking at this funding at the frontline level. It's the least expensive way to pay for it. It's the most humane way to treat somebody, and it helps the entire system to continue functioning, families included, because you're still engaged in your community.
Thank you for that. Zach, you talked about the work that's going on in Oklahoma City. Seems like some work is going on in Tulsa, but I wanted to turn to Mike, who's been in the trenches here for a long time, and you helped create a Better Way program, and that built a collective impact model with 26 agencies. And our reporting suggests that without structural changes, more affordable housing, stronger tenant protections, closing gaps in social services, this cycle is going to continue. And after everything you've seen and built, what is your level of optimism that Tulsa can actually move the needle on this problem?
Next. Yeah. You know, again, we've really done amazing things in terms of building these co-responder models that you referred to, different things, a better way, a way home for Tulsa, bringing all these different agencies together. And I see Gene Bullmash sitting out there from the mayor's office. Raise your hand there, Gene. I want everybody to see you there. He's there working every day on the development of affordable housing in our community, which is extremely complicated. I know that because of the work that we did with affordable housing. It's very, very complex. We've got to have, you know, I don't know if you guys know this, we're housing a lot of people. But we've got more people coming into homelessness than we're able to house. So I think that gets lost in the story, how many people are getting housed all the time. Everybody's working together on that. But I think we've got to tighten some things down. We have to be better at communication. I've just complimented the mayor's office. I'm going to kind of pick on them a little bit while I'm at it. I'd like to see them be a little more forceful out of the mayor's office. Emily Hall does a great job, but I think we need to really push the agencies, law enforcement, working close together. I'm going to just, if you don't mind, just tell a quick story here. So this just happened not very long ago at the Tulsa Day Center. We had a woman who was very ill, very much, our licensed people determined that she was a danger to self and maybe to others, okay? And they thought, well, let's back that up, and they called COPS, out of Family and Children's Services. COPS comes out, COPS interviews her, they concurred and said, yes, she is a danger to self and a danger to others. She needs to be hospitalized. They called the police department. 2 officers showed up and talked to her for a few minutes and determined that they didn't think that she needed to be hospitalized. They got their cruisers and drove off. That's not going to cut it. That will not cut it. So that left them there. So we've got law enforcement making clinical decisions. And when we went to New York City a few years ago, we saw them, they flipped it around. You had licensed, specially trained outreach workers who determined when someone was a danger to self, a danger to others. They let law enforcement know that we need your security and we need your transport. and letting clinical trained people make that decision. I think one of the things we've got to flip that around. And we're going to have a new hospital. We're going to have a lot more beds. How many beds? We're getting 50 more beds, more than that. That we're going to be able to do that. We want people to be short term. We don't want them to be hospitalized any longer than they need to be, but sometimes we need people to be stabilized, to be able to have their medications, their medication regimen figured out. That takes time sometimes. And we need people, and we need to then hand them off and not just turn them out. And that's another thing that we're doing out of the jails, out of hospitals. We're turning people out. That always needs to be what we sometimes call a warm handoff. And that takes a lot of communication, a lot of coordination. And I think those were the gaps. We have great services. They have to be all integrated and connected together.
It's really, really fascinating because it just seems like a few somewhat simple changes could fix a lot of things. So I really want to come out of discussions like this with like a list that we can use to, inform our reporting as we go forward on this. So Garrett, you and your colleague, speaking about the cuts and the impact of these cuts, RA5 reported on the damage from the state mental health funding cuts. And the department described the contract adjustments as routine fiscal oversight, and the providers told a very different story about the domino effects. So how do you navigate, as a journalist, that gap between what the agencies say and what's happening on the ground? What information do you feel like is missing or is not, is needed to really bring some light to this?
Right, so providers told us that, this was anything but routine, especially smaller providers. I think larger providers like Family and Children's Services they have pretty large budgets and they're able to withstand this, at least in the short term. But somewhat smaller providers like the Mental Health Association, they saw about $500,000 in cuts and had to cut a program for adults living with serious mental illness that provided them with support groups and classes and case managers, and so that was a program that was having a lot of positive impact that got cut. And so I think so I think for some of these smaller providers, there's definitely been some really concrete impacts. But it was sort of confusing reporting on it because there were much larger cuts that providers thought they were going to be without a lot of money sometime last year. But then a bunch of contracts got restored. But then there's still contracts that weren't restored.
Kind of a shifting story.
It's really a mess. Yeah.
And one thing I've noticed is that sometimes these cuts occur, and I think there might be an assumption on the part of elected officials that, well, these nonprofits, they're going to step up and take care of it. And, I feel like our philanthropic community is doing their share. I want to kind of bring this home to sort of Ishmael's reporting on folks who are, real life human stories that are struggling with both distrust in the system and the need for services. So for those of you who haven't read the story, Ishmael, could you tell us a little bit about Mikael Vaughn, the main character of your reporting, and just what stuck with you about his story?
Yeah, when speaking with Mikael, he described himself as somebody who was very off the wall, very energetic, but at the same time, he always felt that he was different growing up. He even said that at some points he wanted to wash his brain because he felt like it was full of static. And it wasn't until he was 18 years old when he was speaking with a friend and he was speaking faster than his body was moving. He didn't understand really what was going on. He finally went to Student Health Services, and through a series of conversations, he was diagnosed with bipolar disorder. And it was a pleasure getting to actually hear from his perspective what exactly that was like and the difficulties of managing that as a Black man from North Tulsa. He didn't really have a space in where he could actually discuss how to manage that. So he went through his full hurdles of finding a psychiatrist, medicating himself, and having to decide whether or not he wanted to over-medicate himself and feel a zombie or not take his medications and be liable to have another manic episode. So it was a pleasure getting to hear his story and getting to hear what it was like to have bipolar disorder.
Yeah, and your reporting found that, especially in the Black community, like discussing mental health challenges openly, as you said, in some circles is a taboo. It's you know, there's a stigma against it. And I feel like he responded at social media after we published this and said something effective that he was proud to be able to share his story. Like, it takes courage. So congrats on that reporting and giving him that. I think it gives other people the courage to then talk about their mental health challenges. Let's see, Garrett, is there anything, I really want to hear about the reporting and how difficult this is, especially with people coming into the jail and what is happening to them. Is there anything that could make that easier, just in terms of transparency?
Are you talking about transparency in the reporting, or
just how difficult was it for you as a reporter to find out what was happening when folks who have mental health challenges and other health challenges go into the jail, and like, what is happening?
I mean, definitely with you know, any story about mental illness, there's always reluctance to talk, and jails. I mean, people, it can be kind of embarrassing, especially, I mean, a lot of the people who passed away in this jail, some of them, it was their first time having been to jail, and so there was an awkwardness with some of these families and talking about it, and of course it's really hard to talk about, you know, it's really hard to talk about it when a family member has passed away, to talk to a reporter about that. I think it'd be worth kind of building on what Mike was saying about the lack of communication with law enforcement. I think there's one case that I've found that really speaks to that in a very tragic way. So this was a case of Jeffrey Federoff. He was a 23-year-old living with schizoaffective disorder, and he had just been discharged from a mental hospital, and then he gets out, and his mother contacts Adult Protective Services and the Tulsa Police Department to try to find him. But anyway, he ends up at a Quick Trip at 2 a.m. and the police get called because he won't leave the Quick Trip. It's a very basic trespassing case, and they find him mumbling outside the store. And I mean, you would think in a case like that, that would be kind of a paradigm case of someone you might want to take to an alternative to jail. But instead, they took him to jail, and he's told jail staff he was recently suicidal, but they don't really have suicide watch, but they kind of do. But anyway, they put him in general population anyway, and he ended up dying by suicide shortly after that. And so I think that case really speaks to a problem. You know, I've been trying to talk with mental health providers and homelessness advocates about this, but a lot of them don't really know about it. So I think we're kind of honing in on an issue of like this invisible population of people that's ending up in this jail in a place that, you know, is just not equipped to care for them.
Thank you for that, and thank you for the reporting. So I'm going to just open it up to the panel now and ask some questions that many of you can respond to, and then I'm going to see if there are questions in the audience as well. So the title of this forum is Closing the Gaps in Mental Health Care, and after everything you all have, you know, either researched or reported, witnessed firsthand, what is the single most important gap in the system? I know there are many, but if you could wave a magic wand and fix one of them, what would it be, and who's responsible for closing it?
It's a difficult question because there's so much even, and people want a silver bullet on this issue. It's just not one.
I'm asking for one.
You know, I think the moonshot idea would be to scale prevention services for kids. Mental illness is a disease of the young. Most mental illness sets on by early adolescence. And so what we know is that there are evidence-based programs that we can deploy in schools and in other settings where children and families are that actually have a high degree of success. Scientifically studied programs that have a high degree of success. What if I told you that we could prevent 75% of marijuana usage or 68% of methamphetamine usage? If those numbers were something we could prevent 68% of cancers by doing this, I think we would be interested in doing that, right? But that is the reality, is that we've got prevention programs that actually cannot be funded through traditional healthcare billing sources. They have to be philanthropically funded. There's a little bit of federal block grant dollars that can go to this. But I will say that those sorts of ideas to sort of change the system, how do we start to invest not at the back end where a crisis has happened, it's the most expensive possible thing that we could do to try to figure out somebody's situation in jail or in the ER, and get further upstream and prevent a lot of this. And I will say, my prior question indicated that there's sort of a transition of leadership. And I think one of those points is the legislature. The legislature has passed a lot of amazing mental health legislation in the last several years, and they're passing legislation that is designed to get ahead of this problem a little bit, right? And so I think we need to celebrate that at the same time that we talk about what we need to do is thank the legislature of ours for working on these issues and getting upstream.
Encouraging more good behavior, right? Anyone else want to weigh in on this?
Yeah, I want to weigh in on that a little bit too. Like, so schizophrenia, schizoaffective disorder, primarily, there are exceptions, but late teens, early 20s is when you'll see initial onset of those illnesses. And it's in the same deal as that. So Family and Children's actually has a program that tries to address that. If we can catch that first episode and really intervene in a highly effective way. So the science, we've actually known this for a long time. Repeated psychotic episodes deepens the illness. We've known that for a long time. Our policies aren't really caught up to that, but when we try to really intervene at that first episode and really, really apply a lot of wraparound intensive services, not only to the individual, but to help their families in a lot of ways, we have a better chance of helping that person return either all the way to their baseline or pretty darn close. But we do know that if we keep failing over and over again, that illness, and if it keeps going, that's a lot of times how people end up being homeless. Their families run out of gas, they run out of money, they run out of emotional energy. They just can't do it. And so they'll end up on the streets many times. So the more, it's the same idea, catching it early, intervene early. And Christine, you guys have a great program that addresses that over there.
Yeah, I love that, Mike. I agree, absolutely. And I know it's kind of preaching to the choir talking about intervening early, but we'll take even the beginning of this year, for example, see how we need to work together. But our school systems, first out of the gate are funded by attendance a lot of times. And I'm not an expert in how school funding works, but many of y'all in the room might be. But the first thing that happened when school started this year in our children's programs is our parents were coming in saying, we can't bring our kids in for services anymore. We're told we can't have appointments, we can't miss school, which we certainly understand, and we want kids to be able to be where they need to be in school as well. The problem is that we need families in the therapy appointments too. And it's that perpetuating problem. If we don't let kids go to treatment with their families, then they're not going to get better. And not everybody can have everything addressed at a school-like setting. It's not necessarily appropriate all the time to do trauma treatment at school and then pop back to class. And your parent and siblings can't be in those sessions with you either. And so there really is a need for some outpatient services, but our systems themselves that are sitting here to help families support and grow, learn, etc., aren't working together to allow that to happen. And so parents are pressured not to have their kids miss school. Kids need to come into treatment. I feel like our families don't know what to do and which way to turn. And our parents, we need them in the therapy sessions. Kids aren't going to get better without a safe, stable, strong, supportive, understanding caregiver. So if it's not a parent or a grandparent or somebody who can assist, we're kind of, working with that child alone, and that can be difficult. We do it, but it can be difficult. So they really do need a community of adults or caregivers that can support them in that process. So little things like that I feel like when funding gets tight, we all start fighting each other, and then we're not able to help, and systems can't be as strong as they could be.
Okay, I've got one more lightning round question for you all, then I'm going to open it up questions. So if each of you could tell people in this room and anyone watching the live stream one thing they could actually do to sort of address the, within your areas of expertise, what you reported on, what you work on, one thing they could do to make this issue better, or to elevate it, or to bring it to public attention, what would that be?
I hate to say it, but the onus is on you to understand the system. It shouldn't be that way. The mental health system is like a house designed by 1,000 architects. We've got stairways leading to blank walls. We've got a living room with none of it in. We've got a closet that actually leads to the thing that you need, but nobody knows where it is, right? That's the system that we're dealing with. And until we have a perfect system, it's not going to be tomorrow. We need you all to understand what that system is and do your own research. You're engaged today, so that tells me that you're able to do that. And then help educate your peers, right? Help educate your friends, your family, the legislators who represent you, right? The city councilors who represent you. Talk about it, because you need to be the ones who educate those in your lives.
I would echo that too, and never underestimate the power that you have with your elected officials. The number one entity, a lot of times, that they want to listen to are their constituents. I can go and say something up there, but I'm a provider. And while we have trust and relationships, if they hear from you as a constituent, what you're dealing with, what you've faced, a lot of them will move mountains for you all individually. And if you don't know what to do as an individual, call Zach. He can tell you how to get around it. Everyone knows there's always up there.
You know, I want us to, again, go back to, all of us to think about how we react and what we feel and what we think when we see someone on the streets who appears to be homeless. And again, are we blaming them? And I'm challenging all of us, and I'm challenging myself to, understand behind that this is a larger systemic issue. That if we're going to really make a difference at lowering the number of people who have to live on our streets here in Tulsa, or to end homelessness in some form or fashion, that it's going to take a lot of systemic change. And we've got to get past, one, blaming the individual, and it's their fault, their moral failure, or whatever. And what do we tell ourselves? Ask yourself what your internal narrative is about that. But also, I have been battling for 20-some years the belief that there are other cities who bust their homeless into Tulsa. And people still tell that. And you know who tells it a lot? Law enforcement. But they're not the only ones. And so there's still a belief in that. And I always say, my challenge to them has always been, bring me the name of that town, bring me I'll handle that. Believe me, they don't want to get a call from me. That doesn't happen. Are there people who sometimes come in from out of town? That does happen. People move around some, but most of these individuals are neighbors. They've grown up around us. They're from our community, from our state. They're Oklahomans. And so it's incumbent upon us to help them, but also we've got to change these systemic pieces that keep people homeless.
And Isabel, I wanted to just make sure I gave you a chance to talk about the good work that the Black Mental Health Alliance is doing that really relates to your reporting. Only 2% of the country's psychiatrists are Black, and the men that you profiled said that having access to a Black mental health provider is crucial. So what would you want people to know, I guess, about the work that they're doing?
Yeah, so about 4 years ago, in 2022, multiple Black-owned mental health providers formed a coalition called the Tulsa Black Mental Health Alliance, and their mission is to provide that needed access within the Black community. One of the interesting things that they're doing, one of the organization's amazing skills counseling services, is that they're going into the spaces where Black people are. For example, they're teaching barbers and barbershops how to identify suicidal ideation within their clients. Barbershops is one of the few spaces Black men can go and have their identity be secure and understood. So I think what they're doing is very interesting because they're attacking the spaces where Black people are, whether that be the church or barbershops or salons, and teaching people that discussing mental health is not only important, but knowing how to identify it for somebody that might be silently crying out loud for it is very important.
Garrett, any last thoughts about the reporting you've done and what you wish people knew?
I think just becoming aware about these issues in general is really important, and I think there's a couple of things that the city could do policy-wise that I think could potentially help a lot. One is that I forgot to mention that the county jail from which these arrestees were moved, it had mental health providers on site and medical providers on site, and so they moved all of these highly vulnerable arrestees to this place that has none of that. And so I think one thing that's been being discussed is potentially moving back to that model. It's not perfect. The county jail also has a lot of problems, but it does have it's a much larger facility with mental health providers on site. And then the other thing is potentially just more training for police officers to be able to identify people who should potentially be taken to an alternative to jail rather than to jail.
Thank you for that. I'll open it up for questions, and if you all just want to stand up and say your question, I'll repeat it so that the live stream folks can hear it. Don't be shy, it's a safe space. Yeah?
I'm hearing that there are a lot of boundaries. There's maybe some familial denial, there's stigma, there's anosognosis.
Anosognosia?
Yeah. There's that.
Very close.
And there's no amount of help that someone at COPES can do if a person doesn't recognize or can't recognize that there's illness. So I'm wondering, what can family members, loved ones do, knowing that we don't know where to go to cope with this?
Yeah. So the question is, for the live stream, family members, loved ones, people you care about, those in their life that are struggling with mental illness that either have anosognosia, deny that they do, or don't know where to get the help. Like, how can family members help?
Well, I think we've got to support those family members. Family members need our help and support. I don't know how many times I've heard the story that family gets the person, their loved one, in treatment, and they call over to find out how they're doing, and they're told, I cannot admit or acknowledge your presence, and how that feels. And we got to do a better job as mental health providers getting those releases signed so communication can occur. But we need to support our families and help them understand how much stress you go under. And I don't know if that's getting at what you're asking about, but that's something that I've seen over and over again. Families feel so all alone, so stressed out, and confused. And going back to confusion, Zach, you described that system, you did it really well, of how confusing it can be. Hey, mental health professionals have trouble navigating it, let alone a family member, and we need to support family members any way we can.
And there are other organizations, like NAMI, Oklahoma, that provide some supports as well. And I think part of the issue is, just not giving up. And I know that sounds exhausting a lot of times. But I can tell you a handful of stories of where we have had individuals wind up in our crisis care center or somewhere else, and maybe not on their own will, who have then come back over time and said, this was the time that made a difference. And somebody didn't give up on me, even though I told them over and over again, we don't want it, we don't need you, I don't need you, I'm fine. And something finally took, and the person was able to make different changes in their life and move in a different, more positive direction. And I think that's why we continue to follow up. We continue to try to ask the questions. I don't know that we're always perfect by any means. The release thing is a big issue. We do have our protective confidentiality that we need to maintain as well, and there are lots of reasons for that too. But I do agree that our systems have been moving in more of a direction to look for anybody who is connected to these individuals that we can get a release to something that we can also call, because the supportive, one of the number one factors for somebody to recover or to be able to move forward in this with mental health issues is having safe, stable, supportive systems around them, not just as a provider, but people that they can talk to, live with, live among, whatnot.
And I will say that our Tulsa Documenters program, which is part of the Flyer and Eagle, they did an exhaustive research on like every potential social service program, across the board that helps all different kinds of folks with different specific issues like veterans, sexual assault survivors, gambling issues, addiction issues. So there are 70 different resources in this guide that we put together. There's a QR code in one of these cards, and then just go to TulsaFlyer.org to find the snapshot coverage. So we have a lot of resources there for you all to take and share with your family members.
I'd like to just add, just for a second if I could, the Tulsa Flyer, the Oklahoma Eagle, the Frontier, you guys telling these stories, and we need journalists like never before, and to be able to tell these stories and get these out to the public and interview these families. It's hard for them to talk sometimes, but when they can, sometimes it's a story that compels and really raises interest. Sometimes we kind of can be talking heads a little bit, but these are real live stories that you guys are trying to tell, and I think that moves the needle also.
I agree. The stories that Garrett and Ishmael and all our staff here in the audience have done for this really, I think, bring it alive. More questions? There's so many.
Statement, if I can.
Yes.
I'm Dr. Denise Starr. I'm a psychologist, and I have a family member with schizophrenia. And as I listen to you and the anosognosia and the importance of early treatment, I don't know the answer, but I do know that we need to find a way to open that door to treatment so it isn't a narrow danger to self, danger to others.
Yeah, Dr. Amador, he really promotes using LEAP, listen, empathy, agreeing, partnering, a technique that he developed. It was interesting, he's a psychologist also. He didn't learn it through his training. He learned it working with his brother and developed it in a real life, lived experience type of situation. But it does work, but it takes a lot of, that's what we're trying to do, is train people, family members, professionals, law enforcement, everybody learning to use those techniques rather than some of the other things that we sometimes that are less productive.
Zach, you have a point?
Yeah, just really quickly, Doctor, well taken. So what is the entry point to healthcare, to the healthcare treatment system? Primary care, right? Did you know that 47% of people who die by suicide had seen a primary care doctor in the last month of their life? Did you know that 45% of the time when somebody walks into a primary care office with massive depression, it is actually detected? 23% of the time it is treated, and 9% of the time it is treated adequately. So we have to start talking about primary care being the entry point to mental health care as much as it's the entry point to the rest of healthcare.
Really good point. This lady here, and then, yeah.
I have something to say about biology, like physical health, and what she means with I kind of want to touch on that in a second.
Okay.
So I am really big on prevention, and so one of the things that I've noticed is not even just with mental health is there's a lot of stigma around it and a lot of entry points that can be difficult to find or difficult to come across or like different criteria that you have to meet in order to qualify for different services. So how would you guys look at making it more of a no wrong door, no wrong entry point to where we can come to these services without having to qualify for whatever reason, knowing that we ourselves know more. A lot of the times we know more about what we're facing and what we need than a professional, or not saying that professionals don't know those things, because they definitely learn those things, but as someone with lived experience, trying to find those doors that are open even when we may not meet a criteria.
So how to advocate for yourself as someone that you know you need help. The system puts a lot of barriers in front of you because of different qualification rules. So any advice from you all for this situation?
Well, I don't work for the Mental Health Association Oklahoma anymore. but I know they still have it. It's called the Mental Health Assistance Center, and it was created because we recognized how confusing this system is. So we set it up. Lucinda Morty, as far as I know, she still staffs that, and her job is been to work with people as long as it takes to help them and call back. Let's try this. Call back again. You just keep calling back until you're satisfied that you've got the help you need. We created that. Didn't cost anything because we recognized it was really hard for people to figure out how to navigate that booger to get the services they need. So that's one of the things that we created to try to help people just to be easy access. So I don't know if that addresses your need, but that's what we try, our small piece we try to do.
It's like a navigator to the mental health association.
And just call back as many times as you need to.
Okay. So you have one?
Hi, my name is Leroy Jenkins. I'm a biologist. I was raised by a cohort of people with mental health issues. I just don't think I have them, but nature versus nurture. So I am dealing with them. And so my statement is, my stance is, my position is that mental health is not separate from the body. It is an output of how the body's systems are organized and function. Dr. Michael Levin out of Tufts shows that cells communicate through electrical signaling that act as a control center over the body, guiding how tissues form, heal, and stay connected. That means the body is not just chemical, it's an electrical network maintaining patterns and functions. And so my hypothesis is that mental health reflects a breakdown in that same system at the level of the nervous system, where electrical signaling and brain mapping fall out of sync. What we call depression, anxiety, or instability may be the result of the system expressing the wrong state, not just faulty thinking. So instead of focusing on thoughts or medication, I'm proposing a biological approach. Stabilize the body, restore the nervous system regulation, restore nervous system regulation, that's very important, and support proper electrical signaling. The goal is not to erase memory or identity, but to bring the system back into alignment so the person can function as intended. So here's my question. If mental health is the output of the body's electrical and biological state, should we shift the conversation toward a biological paradigm, prioritizing nervous system regulation, diet quality, including reduced sugar? So I'm glad that sugar ban went down because the kids are kind of, and sleep and environmental stability as a primary intervention instead of focusing mainly on thoughts and medication.
Well, I think it's like not exclusive, it's a both and. I love this question because one of the things I try to tell people when I describe, my family has been very affected by mental illness, and would you be mad at someone who had cancer or diabetes? No. These are just issues. Your brain is part of your body, and I think that understanding and embracing that is part of making people more comfortable about the issue, funding it, seeking care. I don't know, what do y'all have to say about treating the body and the mind?
Christine, amygdala, hippocampus, in terms of with trauma?
Absolutely, and I know Zach has a thought or two too. Integrated care is really where we're moving and where we should have been and always been, but again, that's more coordination. And the thing that I love about where we're working now compared, I've been in the field and I've seen that transition to where we have nurses, we have pediatricians, we are required to have releases to talk to other healthcare systems. We can look into other medical records to try to put those things together, as well as environment, to your point. So really trying to get that biopsychosocial, historical component of how is this person ticking, how are they made? It's not what's wrong with you, it's what's happened to you, what have your life experiences been, where are you from, all those things. But really looking at that integrated care component of, I know it's weird, you're coming here for therapy, but we are weighing you, we are getting your height, we are going to talk to you about diet and sleep and exercise and all those things. Try to figure out what's going on here, right? And what do we need to do? Because the last thing we want to do is treat somebody for something they don't need. If we need to get them on a different pathway, that's where we need to get them, and vice versa. So that's where hopefully we continue to move and hopefully have some more coordinated efforts with that.
Zach, last word?
I think we're going to look back in 20 years and think we didn't know a thing about mental health in 2026. Some of the brain-body connection stuff, gut-brain stuff, is cutting edge in terms of what science is starting to realize. And we're going to see that schizophrenia probably will go away as a diagnosis because it's really like 30 things that are all different and they all present differently to different people. What I'll say about the time that we're living in now is mental health acuity, that is the severity of health issues in our population, is higher now, arguably, than it ever has been. More people have, more children have struggles. Why is that? Well, let's look at a couple of things. This is kind of radical, but let's look at how we've built our cities over the last 50 years. Not walkable, not connected, we don't sit out on the front porch anymore, we hang out in the house. There's 2 neighborhood connections to the main arterial street, nobody can get anywhere on public transit. The human experience is a social experience. The human experience is a spiritual experience in some ways, right? We have to have that sense of belonging, that we're contributing to society. And frankly, the way that we build society, the way that, frankly, a lot of our children right now with the screen time and all these things do have a measurable impact on your risk of developing mental health issues later. We have to go back to what does it mean to be human? And maybe we ought to look at building a society that nurtures what does it mean to be human. So just to illustrate the whole person perspective, I think that it's ultimately going to take to transform this issue, I think is important.
Thank you for that. I know we have a lot of questions here. I guess I want to respect everyone's time because it's supposed to end at 7, and just invite you to come up and talk to the experts here, the reporters, and we'll try to answer your questions best we can. Also email the Tulsa Flyer. I think it's connect@tulsaflyer.org, and we'll make sure to get your questions to the experts and try to get you answers because we want to keep the conversation going, and we really appreciate that you still have questions. So I want to thank the panelists, and I want to thank Healthy Minds Policy Initiative. I want to thank Oklahoma Women in Tech, and I want to thank the journalists who have worked together on this project for months. My staff, the Frontier, Focus Black Oklahoma, the Eagle, KOSU. It's really been a joint effort, and appreciate all of you all coming to hear about it.